Hi, this is Dr. John Bennett broadcasting from Miami. We're broadcasting a conference from Yemen with Ismail Ab-Kebsi. He's the director. I'll let him take it from here. Good day, Ismail.
Welcome, John, and welcome everybody. Actually, we are ready for the first lecture, for the first speech.
Okay,
Excellent.
thank you.
Thank you. It's an honor to be talking to this group of Yemeni neurosurgeons. Thank you, Ishmael, for the invitation. Thank you, John, for setting up everything. Now, I would like to talk about one subject which is very near to me. It's about head trauma, which all of us know. It's one of the most important conditions in our part of the world. And for me, when I go to India or China or Nepal, head injuries are almost half the number of cases that we see, whether it may be due to road traffic accidents or it may be due to some other mechanisms. Head injuries form almost half of the cases. And yet, head injuries are operated using very primitive techniques where we do not use microscopes, we do not use any modern technology, and we just do something which is a 100-year-old surgery, the decompressive hemicranic. Now, I want to go into why head injuries are different and what is cisternostomy. Now, the decompressive hemicranectomy, if you know, is a century-old technique for head injuries. It is often a desperate large measure, and it is done by the junior-most operating surgeons. You know, about 10 years back, when I was a junior consultant, I was called to the theater, and then I was told that I have an aneurysm and I have an SAH. I have an SAH and I have a head injury. So as usual, I told the resident that please make sure the SAH is taken up first, and then I'll come for then you can do the decompressive hemicranectomy later. But then I was called in immediately, so I went in there and I saw this very angry brain. The brain was the dura was open, large dura was open. So that's how we do WFM stage 5 aneurysms. And I started opening the cisterns and I started hunting for the aneurysm. For almost half an hour, I did not see any aneurysm. So I asked the resident, what happened? There's no aneurysm here. So he told me that this is the head injury. So I was angry. I told him, I told you to post the aneurysm first, but you did not follow my orders. So he said, it's because the head injury dilated the pupil, and I had to post him first. So I could not, he had defended himself, but the first thing I thought was that after I had opened the cisterns, the brain was lax. In other words, I had treated that head injury just like an aneurysm accidentally, and the brain became lax. So immediately I thought, why cannot I do the same thing in other severe head injuries? And that is how cisternostomy was born. Now we have a case series of 1,500 cases. Many places all over the world has started and accepted it. There is a prospective trial going on in Lausanne. In Europe, there are textbook chapters, there are many papers. And we have come to know that the physiology in severe head injuries, acute severe head injuries, the edema is completely different from what we think it is. So why does one do cisternostomy? Why does the edema come down? It's very simple. The CSF travels from the supracellular through the Varsha-Robin spaces into the brain. So the CSF from John, I'm hearing a lot of echo. I'm hearing a lot of echo, John.
Yes, we too. There's an echo.
Mohammed,
Sound is
move.
not so clear.
You need to move the smartphone away from you, Ishmael.
Actually, it's so far.
Okay, Mohammed, could you please move the smartphone further away from each other? The two internet devices need to be away from each other.
It's much better now, John.
Okay, it's better.
Okay.
It's better. It's better, Ishmael. Thank you.
Okay.
Thank you, Ishmael.
Okay.
So the point why cisternostomy helps is the concept of CSF shift edema. So we all know that the blood vessels are in the subarachnoid compartment. Now, from the subarachnoid compartment, from the vessel enters the brain, there are small outpouchings of the CSF around the vessels. They are called the perivascular spaces or the Varsha-Robin spaces. They are extensions of CSF space in the brain interstitial fluid. Trauma results in multiple small vessel injury and traumatic subarachnoid hemorrhage. This subarachnoid hemorrhage is mostly of arterial origin. It doesn't raise the pressure like in an aneurysm, but it raises the pressure nonetheless within the systems. And this cisternal high pressure results in a shift of CSF into the brain interstitial compartment from the cisterns. And this is brain edema. So these are the publications. Now, how do we prove it? So we did an experiment in Calgary, courtesy Garnet Sutherland and Sanjay Lama, who is our collaborator. So we made a weight drop model in mice. So that is a weight drop model. 500 gram from 1.4 meters was dropped onto the mice head. And after this, the mice was taken up for a 9.4 Tesla MRI. And you see, this is the pre-trauma images, that is the post-trauma images. The difference in these images are that the intensity of this is very high. So we thought, why is the intensity very high? It should be two things, either could be blood or could be fluid shift. So we had proposed earlier that the blood, there is bleeding in the subarachnoid spaces, the pressure in the cisterns rises up, and there is fluid shift. If you see the mean MR intensity image, mean MR intensity pre-trauma and post-trauma, it is clearly high. And you see in the subarachnoid spaces, there is blood. And the axons and the neurons are separated because of edema. And in the subarachnoid spaces, there is no space at all, no fluid at all. So this was a big proof that CSF shift edema is an actual entity. In the summary of results, we showed that the increased T1 intensity after trauma, and there is fluid shift from subarachnoid compartment into the brain. Now, what do we do if we do decompressive hemicranic let us say that the brain is edematous because the fluid from the cisterns has shifted into the brain. And let's say we open the dura. What happens? This causes herniation of that brain through the craniectomy site. This may decrease the ICP, but it causes severe stretch injury to the brain. It is a wrong answer. And this is what happens. We have seen this. So the answer I'm going to tell you now. We have to open the cisterns to the atmospheric pressure. Now the brain has high pressure and the cisterns have low pressure. The gradient of CSF will reverse and the brain edema will reverse in case of shift back. Now we're going to show you a few. In other words, let's look at this cartoon. This is the brain, that is the cistern. There is subarachnoid hemorrhage. The cisternal pressure goes up and the brain expands. The answer is this. Open the cisterns to atmospheric pressure. Again, we are showing the brain communicates with the cisterns. Subarachnoid hemorrhage rises. This happens. Drain the cistern. Reverse gradient. Brain edema comes down. I'm going to show you some cases. That is a 31-year-old male, road traffic accident, E1, M3, V1, left pupil dilated. What would you do in these kind of cases? There are a lot of very important radiological signs. If you see that, that is a pre-pontine or the CP angle cistern. Okay, the pre-pontine cistern is here, the CP angle cistern is here. It is widened. You see it is widened? You know why it's widened? Because the pressure on this side, the acute subdural on this side has put so much pressure, midline shift. So the parahippocampal gyrus is pushing on the midbrain and causing the midbrain to shift to the right side. And that is why the CP angle cistern is widened. This means that the patient is going to herniate. You can see the large contusion here. You can see there are almost no cisterns seen. Cisterns are not seen. The usual answer would be a decompressive hemicraniectomy on the left side. And this wouldn't really help the patient too much. You see again, see how much edema there is. Post-op day 2, this patient was extubated, E2, M5, V2, detached on the 10th day, GCS 50/15. No decompressive hemicraniectomy done. We only did, we opened the cisterns. See, now the cisterns are completely beautifully seen. The CP angle cistern is still widened, but you see the brain flap, the brain is not coming out. Brain flap is beautifully kept back. So this is one of our papers exploring Varsho-Robin function, unified theory of brain diseases. Cisternostomy, if you are starting off, then easier to start off with the decompressive clinic flap, adequate sphenoid wing removal. After evacuating the subdural, if you look in YouTube and type cisternostomy, you will get the operative videos. You will get a lot of operative videos, and so I'm not going to show those operative videos here. You will get it on the YouTube, and you will get articles on the methodology of how to do cisternostomy. So if you are a beginner, you wouldn't want to open the membrane of umbilicus because it is you can open it only after some experience. If senior people like Ismail who are doing aneurysms, they can do it. But junior residents, it will be difficult for them to open the membrane of reliquest. So after opening the membrane of reliquest, we put a drain into the prepontine cistern. And once, if the brain is lax, you put the bone flap back. And after all these number of cases, our duration is about 15 minutes. Well, sometimes you need advanced maneuvers. So to get into the base, the cisterns are in the base of the brain. The brain is very edematous. So to get into the base of the brain, sometimes, very rarely, you need maneuvers like anterior clinoidectomy, division of orbitomeningeal band, transcavernous dissection, posterior clinoidectomy, access to skull base in a tight brain, and to divide the membrane of reliquest. We need all this. But this is very rare. Usually, if you do a decompressive hemicraniectomy and turn the head to the other side, extend the head, you can easily go along the anterior skull base and you will be into the opticocarotid system. And if you open the opticocarotid system, you will have some more space, and then you can open the interoptic system. You can go in through the interoptic system into the membrane of reliquest and open membrane of reliquest. A lot of people ask me, why does ventricular drainage doesn't work? You must understand the ventricles have only 20 ml of CSF. They are compressed in trauma and they do not communicate with the parenchyma. Cisterns are 120 ml and they communicate with the parenchyma. How do you know this? This is the experiment. So, G-lymphatic pathway, they put ventricular infusions, they put intracisternal infusions. And you see, this is the ventricular infusion. Nothing in the parenchyma. This is a cisternal infusion. In half an hour, everything is in the parenchyma. So this means that cisternal CSF communicates with the brain, while ventricular CSF doesn't communicate with the brain. So your answer of a brain swelling is not actually a ventricular catheter. So this is another one of our papers, Anatomy and Physiology of Cisternostomy. This is another one. This is in the World Neurosurgery. So I'll go to the anatomy of cisternostomy now. So what we are seeing right now is the carotid. That's a third nerve. That's a basilar. And in fact, incidentally, we did this dissection as a part of, I'm part of the WFNS anatomy committee. So I did this dissection in Paris and we found this small aneurysm on the basilar. So that is your superior cerebral duplication of superior cerebellar. That is P1. That is the contralateral P1. That is your posterior clinoid process. That is the third nerve. That is the carotid. That is the optic nerve. So that is the frontal lobe, and that is the temporal lobe. That is the cavernous sinus. There, and this is exactly what we do in cisternostomy. So we are bringing microsurgery into trauma. So you can see the videos on YouTube. And well, I am also in charge of ACNS, the Asian CNS educational courses. We have these cadaver workshops, and if we can even do it on the web. Let me try and do it on the web so that we can interact with you and probably talk to you. While we can talk to you about the kind of trauma that you deal with, and maybe we can talk about cases, and then we can have discussion and we can hang out with many masters from many fields. So it's been an honor. So that would be my first talk. I am not showing the operative video. If you'd like to, do you want me to show an operative video?
Yeah, okay.
We can try it if you'd like.
Yes.
Ishmael, you want to try the video?
Yeah, okay. Just a short, yeah.
Okay. You give it a
For
shot.
a while,
John.
we can see a video.
Okay.
So let me go into, I will have many videos on my Facebook. Are you seeing?
Yes, we can't see the video yet. We see your Facebook page.
How do I get into my, okay, videos. Okay.
Here we go.
Let me show you a good cisternostomy video first, and then, are you seeing the video now?
Yes. You can see the Ishmael,
starting, yes.
So that is after the cisternostomy is done. You can see how lax the brain is. So I'm just showing the anatomy here. That is the optic nerve. That is the carotid. That is the third nerve will be here. So I'm going to, even after opening the optic carotid, that you can see the anterior communicating artery complex here, in here. And I'm opening the membrane of the third carotid-oculomotor arachnoid. I'm opening. Lateral carotid window. I'm opening. This is a video 5 years back. So we will be able to show you more reasons also. And now, once I've opened, that is the posterior clinoid process. That is the A1. Hello?
Yes.
Taking the class. Taking the class. Yeah, so that is a basilar. That is a basilar. That is superior cerebellar. That is B1. This is the basilar tip. Here is the basilar tip. So this can be done only in a very lax brain. So there was subarachnoid hemorrhage which was removed, and then now you can see the entire basilar now. So this is at the big at the end of the cisternostomy. Let me show you something, some cisternostomy which is not good, which is not very good. So here you go. See now acute subdural. Can you see? Can you see?
Yes. Yes, we can see it.
See the pressure at which the acute subdural is coming out?
It's a little cloudy.
Okay. Better?
That's better.
Okay. Right. So the acute subdural is being taken out. I am going into the optic nerve. Even now the brain is a bit full. I have done the cisternostomy. Now I am opening the rest of the dura. Well, in all acute subdurals, you don't need to do a cisternostomy. But in acute subdurals, where you have pressure, you can put this brain into the preponderant system, just like I showed you last case, and see how lax the brain is. I mean, you really don't need to. Now, very bad acute subdural with the burst law. Okay. Again, small incision, not large incision. See the brain coming out? You will see the brain coming out. See the brain coming out?
Yes.
Under high pressure. It's under high pressure. See, brain coming out. So, no need to worry, but you go on the base and you see the CSF welling out. See, CSF welling out. This is the reverse shift. You keep on. This patient, on his scan, there was no CSF at all. But you keep on sucking out. That is the optic nerve. That's the carotid there. You can see the CSF coming out. See? Again. Very badly damaged. Okay. And at the end of it, you can see small incision. Small incision. And you can see the brain nicely pulsatile. Okay. Nicely pulsatile. Would you like to see more CT scans?
What's up to Ismail?
Actually, the condition is so difficult, and if you have a small simple picture just to clarify the procedure, it will be easy for the audience, because cisternostomy is a very delicate procedure, and most of the neurosurgeons are not familiar with.
Yes, Ishmael, I appreciate that.
Okay.
See, one thing I can tell you is, when you start off, you don't want to do a lot of maneuvers. You do a decompressive. When I started off, what I did is I did a decompressive hemicraniectomy. Just extended the head. Let me just take off my screen sharing so that we can see each other.
Yeah, there you go.
How do I stop the screen sharing now?
No, it stopped there. We can see yourself.
Right. So I'm going to show you this.
Okay.
So let us say we start the cisternostomy. We have this large flap, and
Okay.
after that, the thing that you need to find out is you have to remove this sphenoid ridge completely after the decompressive hemicraniectomy is done. Before opening the dura, you need to remove this sphenoid ridge completely, and after that, this orbital roof also, as much as possible, you nibble off. And then once you open the dura, your retractor should come all the way. Let's say the retractor should come all the way down like that. So that one comes to the optic nerve and the carotid and opens the cisterns. So the retractor should be guided by the optic roof, the orbital roof. The retractor should be guided by the orbital roof. So once this comes in like that, then the cisterns are going to be open. Once the cisterns are open, it's fairly easy to get in between this optic and the carotid if you have a microscope. Get in between them and open the membrane of Lilliquist also. Now I agree this is a difficult procedure, but if you open it at least, the opticocarotid window, the brain is going to get lax immediately. It's not going to take a long time. Now I have a lot of colleagues who are doing aneurysms, and it's very easy for them. So a senior like you, Ishmael, probably take the lead. Just treat it like an aneurysm, just like a WFNS grade 5 aneurysm. And I know maybe you do not go for trauma, but your junior colleagues are not going to be able to handle this. From decompressive hemicraniectomy, it's difficult for them to graduate into cisternostomy over a period of days.
Dr. Cherian, actually the approach is very difficult. It's the same as a skull-based approach. And do you think a very, let us to see, a difficult and dangerous approach is the benefit, I mean, is good enough to make a procedure like this? I mean, the rate of the complication in the skull-based approach is usually great, is usually high.
I understand, but can I show you some CT scans?
Oh, yeah, please.
I will show you some CT scans.
Okay.
And then you will see.
We are waiting.
Yes,
of course, some of the colleague he cannot imagine such a big procedure for just to drain the CSF and the subacute hemorrhage. And I think, especially we have here a neurologist who are usually going with the side of the conservative therapy. So how can we convince him to make a big procedure like this just to decompress the pressure and to decrease the ICB? I mean, I have to have a magic argument just to convince our neurologists in the hospital, because they are just agree with a simple, clear procedure, a clear indication, and great result. As such, complicated surgery with no guarantee for the result, I think you have to think more than once. Are you agree with me, Cherian?
completely agree with you. In fact, when we started off 10 years back, this was exactly what people were telling. But I'm showing you some of my older scans. I'm screen sharing now. Then you will see, closing all the windows.
Okay. Whoop, we lost Iype there. So, okay. Iype will just hop back on Ishmael. Don't worry.
Yes. Sometimes the technical side of the procedure is very difficult. Actually, myself, I have no experience regarding this sort of surgery. We have a lot of options to decrease the ICB, which are simple. It is very difficult to understand to make a big procedure like this. It is the same as a skull-based approach. It's the same approach like an aneurysm clipping or other skull-based tumors. I think the risk is great. The complication, they are enough to think again about the indication. And in our society, where you still have a lot of a problem with the family and the patient next of kin, I think you have to consider the benefit against the risk ratio and to think again and again.
Yeah,
Okay,
Ismail,
Iype,
I'm going to show you some scans. You see this patient?
Okay, please.
yes, we can see the scans, Iype.
Yeah, this is a patient who had a traumatic subarachnoid hemorrhage. And you can see this patient was completely okay for 2 days and he just dilated his pupils. You know that 1 out of 9 patients who has traumatic subarachnoid hemorrhage, just grade 3, sometimes suddenly develops edema and they deteriorate. And we had to take him, you see there is a subarachnoid hemorrhage everywhere. And this patient deteriorated and we had to take him to theater and we found severe swelling, severe swelling. And this is one of the reasons why we started thinking that traumatic subarachnoid hemorrhage and aneurysmal subarachnoid hemorrhage has a similar mechanism. You see, we did not do a decompressive hemicraniectomy. We did a cisternostomy, and this brain is quite lax now. This patient went home. Now I'm going to show you another case. This is severe brain swelling. Severe brain swelling. This patient was airlifted to us from the capital, and you see no cisterns are seen. There is acute subdural hemorrhage. There is burst lobe, and CP angle cistern is widened. The other ventricle is dilated because of torsion, and you see it's pretty bad. Okay, this is after cisternostomy. Okay, this patient went home completely okay. Another one. This is a child whom we were called, and with this scan in the emergency, the child was okay. The child was motor score of 5. The cisterns are seen, but suddenly this child deteriorated to motor score 2, and we took him up for cisternostomy. So you see the kind of damage this child had. So this brain, you can see it sitting in the prepontine cistern after the cisternostomy was performed, but you see the brain is not bulging out. You know, unlike in a decompressive hemicraniectomy, the brain is not. You see the severe damage. See the damage here, severe. Now this is the child when before discharge, at discharge, and another patient. Severe swelling. Okay. You see on the left side, no cisterns seen. Okay. Massive mass effect. People would do a decompressive, and even if you do a decompressive, this patient is not going to do very well. We all know that. Okay. So this is after the case. No, brain is not bulging out. Cisterns are open. Brain is not bulging out. So we have so many cases like this to show. And on my Facebook, you can see we always publish this kind of cases. I mean, so many of them. Recently, I would be very happy to show you many more cases like this if you want. And even most of these things are published now. Yes, 10 years we've been going on, and what Ismail told me is the questions that people have been asking me for 10 years. Is it really worth to do such a big surgery for trauma, and is the results different? I can tell you the results are very different. The results are different from day one. It is not only different from later on, it is different from day one. During surgery itself, you will see that the brain swelling is down. Number one. And number two, my point is that the number of cases of trauma is much more than the number of aneurysms. So I think we should stop seeing that trauma is less important and aneurysms are more important. But this is one of the things that we This is one of the things that we are seeing, that a lot of people all over the world, it is a consideration that trauma is emergency and aneurysm is an elective case, and therefore aneurysms are important. It is not so. It is the same importance that trauma and aneurysms have. And if aneurysms, we can do all this skull-base approach, why not for trauma? It is the same life. So I would beg you to change the attitude of people in your country that trauma is less important. And you should do, once you start seeing the less swollen brain on your operating table, then you will be convinced. It is only a matter of seeing it, but it cannot be done by junior residents or junior consultant. It has to be done by somebody who's senior. And if you select the right case for an acute subdural, which you were going to decompress, if you do the large flap and then go and open the cistern, at least the opticocarotid and interoptic cistern, immediately you will see the brain coming down. And this is my point. And once after that, then you can go on to more difficult cases and do all these fancy maneuvers. But just a simple acute subdural, you will see that you will not need to decompress if you are opening the cistern and putting a catheter.
Okay, excellent presentation. I think Ismail wants to move on to your next talk. Correct,
Yes,
Ismail?
Mr. John, actually, it was a great speech that highlighted on a new thing for us. Cisternostomy is still a new issue. Thank you so much. A great presentation and a very excellent job. Thank you so much.